This podcast has been produced on the traditional lands of the Gadigal and Bidjigal peoples. From 2RPH and the Wicking Trust, this is Passing Thoughts. I'm Rob Kaldor. This is the podcast where we investigate death, dying, and everything in between. For most of us, death anxiety sits below the surface. It can show up quietly, in sleepless nights, in health scares, in the sudden loss of someone we love, or it can roar when a diagnosis lands, when time feels finite, when the questions get bigger than the answers. What does this have to do with psilocybin, more commonly known as magic mushrooms? Connie Mason takes up the story with two fearless clinicians.
Dr. Margaret Ross is a psychologist and Dr. Justin Dwyer a psychiatrist. They're palliative care specialists who've been working with a group of their patients for the last few years to understand if psychedelic-assisted therapy might help those patients to manage depression and an intense fear of death. The research has taken them from the suburbs of Melbourne to the depths of the Amazon jungle. And certainly I want to get into that fascinating journey. Now, many of us have a fear of death and dying, but what is it that makes that fear so intense for your patients?
I think when you work in palliative care, people who have been completely blindsided by a terminal illness and it completely upends their life, their sense of future, and it can be paralysing in terms of how much longer have I got, trying to get on with life or get on with their bucket list, but actually their everyday experience is punctuated with these thudding reminders that life is short and it's coming to an end. So it's very difficult for them, that precious time with family, unimpeded by fear and concern about how it's going to end, when it's going to end. Myself and Justin have worked collectively 2.5 decades working with people who are at end of life. And when you're unable to help them with our usual means, talking therapy or medication for a depression or anxiety, there's very little that we can do. I think when you're faced with that distress on a daily basis, you feel that as a clinician. We feel the echoes of their distress and we hit the limits of what medicine can do and also what mental health can do. So we were really looking for something, anything that could help get to this fear of death, which is very difficult to, I have to say, to get to just through talking therapy.
So you decided to give psychedelics a go. So why psychedelics?
There was some very interesting research that had been coming out of the US back in the 60s, but then, fast forward even to 2000s. And in 2016, there were two very important studies that were published at Johns Hopkins University where they took a group of people who had cancer and were very distressed about their diagnosis. They gave them psilocybin, the psychedelic compound, and they were able to see very rapid and very enduring reductions in distress associated with the fear of death. I'd seen this research and I spoke to Justin about it. I'd done research in a previous life at Melbourne University Department of Psychiatry, so I knew how to run a clinical trial. I hadn't planned on going back to research at all, but then seeing this, I thought, what have we got to lose? We've got patients that we're seeing, they do not get any relief from.
And you mentioned psilocybin. Can you tell me about that?
So psilocybin is one of the many compounds which occurs naturally in some groups of mushrooms, commonly called magic mushrooms. It's the main compound which produces the peak psychedelic effects. And so when we used it in our trial, we didn't use it from natural source. We weren't using mushrooms. It was synthesized in a laboratory and presented to us in capsule form and has quite similar effects to the magic mushrooms themselves. The effects last 4 to 6 hours once people have ingested the drug. It's quite safe medically. Usually, if people get side effects, it's usually things like a bit of an upset tummy at the start or slight elevation in their blood pressure or their heart rate that's usually not significant. And then it begins to produce these really odd peak psychedelic effects, which are really where the psychotherapeutic work can begin to take place on a different level. And then over about the next couple of hours, generally people ease out and it becomes much easier There's often a great sense of unity and connection and a sort of a capacity to enjoy music and think about things quite differently. And then normally 8 hours later, people are sitting up.
Can you tell me about your patients? How did they feel about taking psychedelic drugs?
I think the main thing to appreciate is the state they were in at the time. These were people who had been cut off from any sense of their past. Their future had become simply a matter of waiting for the moment of their death. And they were trapped in this endless moment of now, which was all about feeling disconnected from things, nothing having any meaning anymore, that there not being any sense at all, actually, of things being understandable. The world became this sort of surreal, empty place. These were people too that had close relationships, loved ones, that there were little occasional moments where they would see something in a completely different way and they would realise that something is happening to me, not everyone else, but to me, that makes me different. These were people who'd done everything they possibly could as well to try and feel better. So when they came along, many of them were ready and they didn't regard it as, I'm going to take an illicit drug or I'm going to take these magic mushrooms and have some, mystical insight of seeing God and it's going to make me better. These were people who just needed their world to feel different and were really in a horrible state of despair.
And how many people were in the trial?
So we recruited 25 participants who had an advanced terminal illness, by which we mean stage 4 cancers or advanced illnesses that were non-cancer. So, for example, end-stage lung failure, end-stage cardiac failure, motor neuron disease. We were really at the edge of what had been done before. We were working with people who were medically very unwell and at various stages of their illness. Some were better than others, and some indeed actually died before we could finish our follow-up 6 months later because of their illness.
Tell me about when they come to you and they're going to have this dose of psilocybin. How is it administered and what do you do?
It's nested within a really structured and quite intense psychotherapy program. So it's not as though they would just come along, be screened in, and then would be presented with the pill. The lead up to actually swallowing it, though, is a lot of work. It was literally 7 to 8 hours of psychotherapy work over the 3 days beforehand leading up to it, and then a full day of hard work dealing with whatever was arising, then followed by even more intensive psychotherapy.
They get 2 doses, is that right?
Yeah, the first dose that we gave them was what we would call a double-blind dose, which means that we had to test the effectiveness of the psilocybin against a placebo. It meant they didn't know what they were getting. They were blind to the condition that they were getting, and we were blind to it as the therapists as well. So the only person who knew was the pharmacist, who was going to randomly assign them to either psilocybin or getting placebo, which we use niacin. Niacin, when you take niacin, it gives you a big flushing response. So if you've never had a psychedelic before, you don't know if it's coming on. So we had to have what we call an active placebo in that way. So the first dose was half of the group were given psilocybin and the other half were given placebo. So we had to compare that. That's basically the gold standard, and then you can tell if it's more effective. Being told you're going to take a pill can create, 35%, I think, of response in clinical trials. 6 weeks, 7 weeks after that, we then offered people an open label, what is called an open label dose of psilocybin. So we didn't feel right about people going, oh, sorry, you didn't get the active drug. We didn't feel right about that. So at least people had at least one experience of the full treatment. And then we were able to compare whether 1 dose versus 2 dose was more effective. And actually, even our data suggested, just to look at the reductions in our depression and anxiety, that 1 dose was probably sufficient to make the most impact. But if you talk with people in the interviews, they actually really did a lot better having a second one and being able to really integrate some of those findings, because it's quite a profound experience, very difficult to articulate. They can have quite transformative, quite meaningful and beneficial experiences that are very difficult to describe in words. So having that second dose was able to give them a deeper understanding of what was taking place. At the beginning, I had seen what was possible here, and I went, we can potentially offer this to our patients. Justin went in as an open-minded skeptic, which was very useful, actually. You need that in research. There's so much of science is not true until it's actually true. So we had to test whether this was actually going to be useful. And I was very excited by it, but he was much more grounded about it. So I knew, obviously, from a science point of view, what we needed to do, but we approached it from different angles. I think that my sense was having really immersed myself in the literature, not only the literature, but also understanding the historical uses of this, in the sacramental uses of this in Indigenous contexts, and really understanding the profound spiritual kind of experiences that can take place. That was just not in Justin kind of language at that stage. Justin is psychoanalytically trained, purist kind of in that way. I was much more into mindfulness and contemplative types of psychotherapeutic experience and somatic kind of psychotherapy. So we came at it from almost completely different ends of the continuum and somehow had to work together as therapists. And we'd never done that before. And this is one of the unique things about this treatment is that you have to work as a dyad. And it's like a dance. You had to learn how to work in this very different way.
Well, knowing what comes next, I'm thinking that, Justin, for you, this experience that your patients had caused you to question a number of beliefs. Were they able to communicate what they experienced?
During the actual experience, often they would be saying things or occasionally telling us what was going on, and then afterwards, often they would recount some of the things. But it's such an exhausting and overwhelming day. Generally, we would leave people to rest and not ask too much following the dose. But the next day, when we saw them, and certainly the week after, that would often be when the things that took place began to emerge, whether it was in their recollections of what took place on their day, whether it was in dreams or hearing a piece of music, for example, because music is a really fundamental part of this therapy. And so it could be listening to music afterwards that might bring back aspects of their experience.
And what music did you play?
Oh gosh, that's a whole other episode. I think it wasn't Hendrix or anything like that, but it sort of has to follow the arc of the mechanism of the psilocybin. So there's kind of an onset, and then there's a peak phase, and then returning to the waking world, if you like.
So this really had a beneficial effect on your patients, but it had an effect on you because of what you did next. What made you decide to travel to the Amazon?
We both travelled there. We both travelled to this community as part of our own development as therapists and wanting to understand what was really taking place here, but also too wanting to have it in a completely different context. When Marg and I travelled to the Amazon, we were fortunate enough to be invited into this very small community. They traditionally use a huge number of plant medicines, one of which is called ayahuasca, which is it's a mix of two plants, and they're sacred plants to the people in those communities. Ayahuasca it's taken by the whole community.
I'm presuming that this ayahuasca has similar effects to the psilocybin.
They're very similar plant medicines, and they produce very similar experiences. Their conception of these things is totally different. They do not regard death as being a final finish. They remain connected to their ancestors, to their culture. They take these medicines and travel together to these places to reconnect with these things.
Ayahuasca itself actually means the vine of the dead. And it was a way of them connecting with their ancestors and accessing a spirit world, as it was told to us.
So those communities have a closer association with the afterlife than we do in Western society. And is this a result of the way that we approach death, do you think?
I think it's so much bigger than that, because it's not just their approach to death, right? Their concept of things like ownership, of what the world is, of how they live in that place is so totally different and so deeply connected. They do not view themselves as being separate to the world around them or from one another necessarily. But one of the issues we have with dying is that here, Death is this like public phenomenon that happens to other people. It happens in this hypothetical kind of way.
It's shut away in hospices or hospitals, and we don't want to look at it. We're very death denying.
It's very medicalised.
Very medicalised. The more we shut it away, the more terrifying it becomes, and it becomes an annihilation of ourselves. Not the case at all in the community that we will be set. You're in the Amazon, you see animals die. So they're in this cycle, very embedded in it. The beauty of what our participants were able to experience was something similar, whereby they felt this sense of part of something bigger, and not just part of it, but embedded in it and essential to it, not standing apart from it. And it was interesting because in the West, we've got such a variation in terms of how we sit with and understand death.
As a result of this experience that you did make a film or a documentary, and Lynette Walworth, I believe, was the producer.
So Lynette connected with Marg first, a couple of years before this.
The reason being she had done a previous documentary called Awavana, which was about the first female shaman. So the first female who was able to offer ayahuasca to people, and they were in the Yawanawa community. And she did a virtual reality piece around that, which was almost like a psychedelic experience. What she found when she offered this as an art installation is that people came out of it and went, oh my God, that is exactly like when I had ayahuasca, or exactly like when I had psilocybin. So it brought that psychedelic experience back to them just by having a virtual reality headset on. And so she contacted me when she heard I was doing this research and said, look, I'd love to talk to you about this because I've got this virtual reality artistic piece, people coming out going, oh, it reminds them of their psychedelic experience. Then COVID hit and we had to shelve it for a little while. But then beyond that, she said, can I follow some of your patients?
For your patients, it gave them comfort. Was this because they saw the possibility of an afterlife that they hadn't previously considered?
Oh, look, I think there were some people certainly who had experiences of a kind of a life and a very vibrant, connected belonging in some other place after their physical demise. Absolutely. And there were some people as well that came into it who had a spiritual or a religious sort of practice already, for whom this completely like consolidated and gave them this personal experience of being known and held by their God. But I think one of the bigger things, though, was that when they emerged from it, they were no longer just sitting around feeling as though they were waiting for death. They were now experiencing every moment as rich and full and sacred. They were able to make choices now about things that before they just did automatically or in an unthinking way that they always knew were unhealthy. They were able to address bits of unfinished business in their life. Some of them were able to reclaim things from their childhood that had been stamped out of them for different reasons, whether it be things like dance or music or creativity or these sort of sensual aspects of being embodied. These were people who decades later, afterwards, found themselves in a very organic, very affirming way, able to live like that.
And what about for you? Did that have an impact on the way that you viewed your life?
How could it not? You'd have to be pretty boneheaded to come back from something like that and go, I'm back now, it's back to business. It's certainly, in terms of our work, it changed our work in this way pretty profoundly, because beforehand we were sort of talking with people about when you take this, you've just got to let it happen, you'll get through it, you'll be fine. But what we learned over there actually was, because you're in this space together, you're there in an actual way, you can be active, you can make decisions, you can choose how you address things that you've always been bothered by. That for us was actually a huge shift in the way that we were working. And, from a personal perspective, an experience like that, it calls into question many things in your life that you've just taken for granted, things that have just sat there the same, unchanged, this kind of locked-in status quo that feels too big or too hard to manage. Your eyes can be opened to those things. Whether you do anything about it or not is, of course, another a whole different kettle of fish. But you can, I think, come back from an experience like that and see differently.
Did you see it as an afterlife or place for after death, or more as a vehicle for enhancing your experience of life as you were living it now?
Oh, my God, Connie. What kind of question is that? How am I supposed to, what do you want me to say? I've got no idea. All of the above. Yeah.
One of the quarrels that Justin and I had always had at the beginning of this was that idea that he just spoke about, which is that whole, it's a drug, it puts nothing in your head, it's all about, and I'm like, oh, I don't know if I'm so sure about that. And so we were never really on the same page in that way. I was, I guess, a little bit more, I feel like I had more permission to wonder about those sorts of things. I don't think Justin had that by virtue of his discipline. For me, it was like, wow, we can go and experience this. And I can feel and understand Justin's reticence in being able to answer that question, because when you do have a psychedelic experience, something that is just not available to you in your waking state, and really difficult to make sense of in your waking state, that is past, present, and future collapse all into one. And you can experience deities, sometimes not, sometimes afterlife. And in the case of our patients, deceased loved ones, that happened quite commonly in our study. We saw that with people who had visited loved ones who had died, and which brought them enormous comfort and solace. But I think it's a surprising outcomes of this is that it had lots of side effects that were not easy to articulate. The word, I guess, our teachers would tell us, it's sort of transcendent. That's not where psychology and psychiatry rests. So it was very new to us to talk with people about, they come out and they'd go, oh my God, I saw myself being propelled into the cosmos and watching myself getting reborn again and again. And it was absolutely profound, and they were just in a state of awe. And then they go, what do I do with this? And how do I tell people without sounding like I'm absolutely insane? It's a very difficult place, beautiful place. It can be quite profound, but difficult to know where to place that. And language is not an easy way. I think almost every single one of them came out and said, I don't have words for what I just saw. I don't have words for what I just witnessed. It was profound. I think out of the 35 people, we had 31, for maybe 4 people who didn't have a response. They just go, I didn't like that. I'm not doing that again. Made them anxious. It's hard work that you have to do some very profoundly personal and difficult things, but also awe is not just beautiful, it can be terrifying.
This experience was effective whether or not you had a prior belief in an afterlife.
It in some ways enriched it.
Has there been any professional backlash to your research?
Interestingly enough, no. We were absolutely expecting it. We thought that there would be quite a bit of backlash at the beginning, and one of the things that, particularly at St. Vincent's, that they were supportive and said, okay, we need to own this, rather than wait for people to go, oh, this is a terrible idea. Why are you doing dying people mushrooms? Obviously it came with a stigma. It had a lot of political baggage, a lot. So the thing that we were very mindful about was the socio-political baggage that psilocybin had from the 60s, from the Nixon administration. And so we were prepared for this backlash, and we were going to say something along the lines of, because had we had those questions, we would have said, if you're saying that it's unethical for us to be giving psilocybin to someone who has distress, potentially helping them, is saying it's not ethical to give people opiate pain relief based on what we know about street users of heroin. This doesn't make sense. If something has a potential therapeutic effect here, and you're taking it at you're putting it in a completely different context, where there's clinical supervision, people we're well screened, thoroughly prepared and supported through this in the context, as Justin said earlier, in the context of a psychotherapy framework.
So I'm wondering where to from here.
So I think, look, it's only recently just emerged from only being able to be used in a clinical trial to now being able to be prescribed by authorised senior doctors. The difficulty is that the way it's now able to be prescribed is under very strict conditions, and it's for one diagnosis. and that diagnosis is treatment-resistant depression. But we're not talking about that here. What we're talking about is the sort of existential crisis, collapse of your world when you know that you're going to die. And some of those people, absolutely, I could diagnose you with treatment-resistant depression. But actually what they're coming along with is not that. So, I think that it's something we would like to see happening and being offered in public hospitals. We would like to see it being offered in palliative care services, and have been working with other clinicians in other places to see that might become something that's on offer. But the next bit, I think, is there's also questions too about who funds it, because it's really expensive in terms of 20 hours of 2 therapists, right? That's a big chunk of change. So there's questions about who funds it, where it fits in. At the moment, it's really in its infancy. We've certainly come across many colleagues who are interested and who are beginning to work in the space, and very interested palliative care doctors and oncologists and therapists and GPs who are really starting to think about where all this would fit in. I do think it's a few years off yet actually being something which is on offer and available.
I think it's on the horizon, though. I think the broader implementation of it, this type of treatment, will likely come with the completion of phase 3 trials in the US, which are coming to an end. It means then that we may be able to get subsidised treatment.
A big thank you to Dr. Marg Ross and Dr. Justin Dwyer for sharing their unique experience at the cutting edge of death anxiety treatment. Thanks to Connie Mason for bringing us this subject. Before we go, one of the key elements identified in Connie's chat with Justin and Marg was the important role of music. So I thought it would be interesting to share some of the music they use in their therapy. You can listen to it now. I've also included a few quotes from their patients who have been through this process. This is from a 40-year-old woman with stage 4 breast cancer.
It takes you out and in, out of space and out of fear, out of pressure, out of anxiety, out of illness, trauma, heartache, bitterness, anger, irritability. In touch with love, with peace, with healing, with beauty, with awe and wonder and joy and amazement. The universe and yourself. I am whole again and strong.
This is from a 60-year-old with metastatic prostate cancer.
I feel so much happier. I know I am dying, but I'm not scared. It was beautiful. I can't put it into words. It's given me so much peace.
This is from a participant's partner.
He was so calm and peaceful. People kept commenting how peaceful he was at the end. I believe his experience with you both and the psilocybin was so beneficial. I wanted you to know how grateful I was.
This beautiful piece of music is an excerpt from Blommer by Jacob Pavek and Philip Daniel, and it's available on all streaming platforms. Passing Thoughts is made with the support of the Wicking Trust and the team from 2RPH, with special thanks to Marty, Veronica and Station Manager Barry. And just a reminder, we want to hear from you. If you have feedback, topic suggestions, or just want to share some of your own experiences, email us at passingthoughts@2rph.org.au. From 2RPH, this is Passing Thoughts. I'm Rob Kaldor.
This is a Radio 2RPH production.